happy to have you here to chat with Medicare, what it is, where it fits into your life, how to think about it, and how to evolve your Medicare planning as your life changes. I'm Brad Newman. I've got Dave Plante with me from Fort Pitt Capital as well. And today we're going to chat with Scott Dardick about the ins and outs of Medicare planning. So on behalf of everybody here at Fort Pitt, we're pleased to present these webinars. For those of you who aren't familiar with the firm, we're an investment management and financial planning firm that was founded back in 1995. I think a few of the things that make us unique are, first and foremost, we do all of our investment management, make all of our investment decisions, and do all of our financial planning in-house. We don't farm it out to a third party, which I think is really kind of bucking industry trends. We do use a team approach to provide all of our clients with a boutique level of service. We've got a lot of scale and a lot of things that we can bring to clients, but we want every client to feel that they're our only client. And I think we also take a holistic approach to every relationship. And this means not just retirement planning and working with clients on their investments, but all aspects, of their financial lives. And while people typically come to us predominantly for the portfolio management and financial planning aspect, we're here to help them with things like charitable planning and social security planning and intergenerational gifting and things of that nature. So just to take a quick few minutes to introduce ourselves. Like I said, I'm Brad Newman. I've been in the industry for, my goodness, over 25 years, with Fort Pitt for over 20 years. I'm located here in central Pennsylvania with Dave, married with 2 children, both of which have miraculously made their way through college. So I've got a little ways to go before I have to start worrying about Medicare decisions, but every time we do this webinar, it feels a little closer. So I pay a little bit more attention every single time. Dave, would you share some of your background?
I've also been in the industry for a little over 25 years. I've been with Fort Pitt now for a little over a year. I also have 2 boys, married 2 boys. I'm living in Boiling Springs, just about 25 minutes from Harrisburg, and pretty excited because I'm about to become an empty nester with my youngest attending University of Tennessee in about 3 weeks. So we're excited about that. And with that, I'd like to give Scott a moment to introduce himself.
Thank you, David and Brad. Yeah, I'm Scott Dardick. I've been doing Medicare and individual sales for 15 years. I have 3 children. I have an oldest son who's a professional drummer and works out in Nashville. I have a son who's a state attorney in Virginia, and my daughter's in medical school at West Virginia University right now.
Just for if you'd like to interact with us today, if you are on an iPad or an iPhone or any kind of phone, you just tap the screen and you'll be able to get the handout. You can see the Q&A right there if you'd like to ask questions. And if you're on a computer, what you'll do is same thing. Oh, sorry, we're still on the device. If you're on a computer, it is, you'll see the little bar down the bottom. Hit that Q&A button and a box will appear. We will try to get to as many questions as possible. And if we don't answer your question, one of us, either Brad or I, will get in touch with you to try to make sure we get that answered. And with that, we'd like to kick off our little webinar here. Brad?
Perfect. And one more housekeeping item, Dave. If you see us looking down at phones or at another screen, we're just trying to manage some of the questions as they come in. We're not multitasking on you. So, Scott, let's maybe start if at the very basics, if you could give us a little bit of a review of some of the Medicare basics and maybe a history of Medicare, kind of how we got to, the program as we know it today.
Absolutely. So, yeah. So, today we're going to be discussing all these questions here. When can you enroll? What's covered? What options you have? Dave, if you go to the next slide. So, Medicare is a program that started in 1965. It's a health insurance, and it was designed for seniors. You must be 65 or older is what it was originally designed for. There are other ways of getting it. If you qualify for Social Security disability, you can get it at any age, or suffer from end-stage renal disease. You can also get on Medicare at any age. Um, so for most people, though, it's when they're first turning 65. Good. So original Medicare comes in two parts, Part A and Part B. Part A, there's no premium for if you've worked 10 years or 40 quarters, you or a spouse. Part B, however, there is a premium for, and that chart is showing what you pay. It's based on household income. So in that first green section there, if you see if you're a single individual, you make $106,000 a year or less, it's modified adjusted gross household income. That's what the Social Security RIS is going by. You'll pay $185 a month for 2025. These numbers can change every year. We'll know what the new number is in 2026 at the end of October, which is the end of the government's fiscal year. If you're a married couple, it's double, $212,000. Again, it's household income. Now, if you earn above those figures, you can see, and I won't go through all this 5 different levels, but they have different income ranges, and you pay more for Part B, and you also pay more for Part D, which is prescription drug coverage, which I'll cover in more detail later. But this is called IRMA, Income Related Monthly Adjustment Amount. Now, what happens when you first apply for Medicare is Medicare pulls your tax return from 2 years ago. So currently they're using your 2023 tax return. They're going to go to the IRS, find out what your modified adjusted gross household income was, and then they're going to start billing you at that rate. If you're drawing Social Security, they're going to take that monthly amount right out of your Social Security check. If you're not drawing Social Security, they're going to start billing you quarterly, 3 months at a time. Now, these are individuals, not per household or per couple. Each person pays that rate, $185, which is where most people are in the green section. Now, if you're first applying for Medicare and say 2023, you had a big income year, but in 2024, you had lower, you can file an appeal and request it be lower, but you have to have a tax return to justify it. You can't just tell them, hey, I retired, I'm going to make less money. So you'll be stuck paying at that higher rate until you can show a tax return that lowers you to another rate.
Awesome. Hey, so Scott, we know most people know that Medicare starts at 65. Can you explain, how the enrollment actually works?
Yes. So this is can be a bit confused for people. So it was designed for 65, and Medicare gives you a 7-month window, 3 months before the month of your birth, the month of your birth, and 3 months after. That's your window to enroll into Medicare. If you wait past that and you have no other insurance, you can be penalized for getting Part B late. There's a late enrollment penalty for Part B, which I'll explain in a second. So that's your window given to enroll to start Medicare. Now, if you're drawing Social Security, which you can do as early as 62, you'll be automatically sent a Medicare card if you're already on Social Security, because you have to take Part A with Social Security. Part B, you can defer if you're going to continue working past 65 and you want to stay within your employer plan, then you can defer Part B and not pay that premium. And that's
go ahead.
No.
I was going to ask if there are penalties for enrolling late.
Yes. So if you do wait past that, you can jump to the next slide, but I'm going to come back to this one, Dave, if you don't mind.
Sure.
The late enrollment penalty, if you don't sign up during your initial window, it's 10% of whatever your Part B premium, which is, of course, based on your income, 10% of that tacked on monthly for the rest of your life. And as the premiums go up under Medicare, so does your penalty, because it's a percentage of the premium. So you want to avoid penalties at all costs, because it can get very, very expensive. So if you are in your window turning 65 and you're either on individual health, you don't have an employer plan, you definitely want to sign up. Now, if you don't mind going back to the previous slide, Dave, there is an exception to this. And the big exception, and this is what confuses a lot of people. If you are working for an employer and that company has 20 or more employees, and that's the key, they must have 20 or more employees, then you can, and that coverage has to be what's considered creditable under Medicare, which means it has to be at least as good as Medicare, which almost all employer coverage is. As a matter of fact, if it's not creditable, the employer has a legal obligation to tell you their plan's not creditable, so you know to get Medicare to avoid the penalty, but majority are. So if you're working for a company with 20 or more employees, you do not have to sign up for Part A or Part B or Medicare. You can stay on your company plan. And then when you decide to leave your company plan, you get a special election to pick up Medicare without any penalties. There's just an added step when you apply for Medicare because you need what's called an L564 form. It's just a form you're going to take to your employer. They're going to test that you've had coverage since you've been 65. You turn that in with your Part B application, and that gets you out of the penalty. Now, if you work for a company with less than 20 employees, you must sign up for Medicare when you turn 65, because if you don't, you will be penalized after. And even worse, with less than 20 employees, the group plan that you're on, the coverage through work, they only have to pay the portion Medicare wouldn't have paid for. In other words, they expect that you have Medicare. So because your work coverage is secondary to Medicare with less than 20 employees. If you ended up getting Medicare with 20 or more employees, Medicare would be secondary to the work coverage. Therefore, you don't have to get it. So Medicare is primary with less than 20 employees and your work coverage is secondary. More than 20 employees, your work coverage is primary, and Medicare, if you got it, would be secondary, but there's no reason to pay that Part B premium and have the work coverage. So you should just opt out of it.
And Scott, just to emphasize that, you said that if you enroll late, that 10% penalty, you pay that forever. For the rest
Forever,
of
never
your
goes
life.
away.
Wow.
Yeah, it can get very expensive, so you want to avoid that. And as I said, the last way is if you can qualify for Social Security at any age. If you've had a Social Security disability, you have to have it for 24 months or 2 years, then you're automatically eligible for Medicare. Or if you're on end-stage renal disease, that's another way of getting Medicare. And there's certain windows. You have to be on dialysis for 4 months, and there's certain rules for that. But yeah, you definitely want to avoid the penalty.
Excellent. So, how is Medicare impacted by programs like HSAs and COBRA?
So this is a very a good question, very confusing when you're working, because a lot of companies have gone to HSAs. Now, HSAs are health savings account. That's where you and or the company put pre-tax dollars into a bank account. That's your money. So when you leave the company, that money comes with you. So you're putting in pre-tax, and you can use those funds to pay co-pays, deductibles, or anything that the IRS says you can use pre-tax dollars for medical. So with Medicare rules, you cannot have Part A or Part B and contribute pre-tax dollars into that account. If you do, or your company does, you have to pay income tax plus a 6% excise or penalty tax on top of whatever money is put in there. So the basic rule of thumb is if you're working for a company with more than 20 employees, and you say, I want to stay on the company HSA, then do not take Part A or Part B, even though Part A is free. And if you contacted Social Security and say, oh, well, you're eligible, it doesn't cost you anything, go ahead and take it. They never ask if you're in an HSA. And I've run into a lot of people that get caught with that and end up having financial penalties as a result of that. So now, if you do stay on the HSA and you're working for the company with 20 or more employees, and then say 2 years later, you decide, okay, now I'm going to retire, you want to stop contributions 6 months prior to when you want Medicare Part A and B to start, because Medicare is going to do a 6-month look back, and any money put in that plan in the past 6 months is subject to income tax and penalty. So you need to stop contributing at least 6 months prior to when you want Medicare to start.
And how about COBRA?
So COBRA is another confusing thing. So if you're working for a company and you're leaving the job at age, say, 64, or before you turn 65, as soon as you turn 65, you have to leave COBRA and go on to Medicare. If you're past 65 and you're working for a company and they offer you a COBRA and you're leaving, COBRA is secondary to Medicare. It's just like there was 19 employees or less. You need to get Medicare because Medicare is primary, COBRA secondary. And COBRA is usually so expensive, most people wouldn't want to do it on their own anyway. But a lot of times they're running into situations where they're either laying off people or letting people go, and they're saying, well, we're going to pay COBRA for 6 months for you. And they're past 65 and say, okay, great, doesn't cost me anything. They just get COBRA. Well, they're supposed to still have Medicare first because the COBRA company only has to pay what Medicare would not have paid for. So, which is for Part B, Medicare covers 80%. You're responsible for 20%. So in this case, the COBRA is only picking up the 20% Medicare wouldn't pay for. So if you don't have Medicare, that means you're paying 80% of all your bills, and you don't want to be in that situation. So bottom line is, if you're going on COBRA, you got to get Medicare if you're eligible.
Scott, there's all these different plans. Oh, there's a slide, A, B, C, D supplements. It's just beyond confusing. Can you
I'm going to try
kind
to
of walk
make
through
this
some of that?
clarify. Absolutely. Thanks for that question. Yes. So I'm going to go through some of this and hopefully clarify some. You're not going to have to remember every single number, nor do you have to, because these change every year. So the numbers I'm going through with you, like that Part B premium chart, that's for 2025. And the numbers I'm about to show you can change every year. Again, we won't know what those are till the end of October, which is the end of the government's fiscal year. But so with just original Medicare, if you just get a Medicare card and you say, okay, great, I've got health insurance, which is again Part A and Part B. Part A is no premium. Part B, you're paying the premium for. Well, you're exposed to a lot of cost under Medicare. So Part A, which if you ever looked at a Medicare card, it says hospital, but that's misleading because it only covers room and board of a hospital, does not pay the doctors that treat you. That's what Part B pays for. So Part A is room and board of a hospital, skilled nursing or rehab. Now, rehab is not long-term care. Medicare does not pay long-term care. Rehab is only 100 days as long as you can be in for any one stay. You also must have a 3-day hospital stay. You're going to recover from something, and you have to be improving each day or Medicare kicks you out. So it's just for skilled nursing and rehab. It covers some hospice care, blood transfusion, some home health care, mental health care, inpatient mental health. For 2025, it has a $1,676 deductible. So if you had to go to the hospital for room and board, you're going to pay if you just had a Medicare card, you're going to pay the first $1,676. Then if the next 60 days, you have no additional cost. But if you're in longer than that, days 61 through 90, you have a $419 per day copay. And if you're in longer than that, Medicare gives you what they call lifetime reserve days. It's 60 lifetime reserve days. So you only have 60 days to use throughout your entire lifetime past that 90, whether it's in one long stay or multiple stays. So days 91 through 150 is double, $838 per day copay. So if I was in the hospital 150 days straight and all I had is a Medicare card on the 151st day, I have no more coverage for room and board. It's all coming out of my pocket. Part B that you're paying the premium for, that's covering everyone else, doctors, labs, ambulance, durable medical equipment like wheelchairs, crutches, oxygen, so forth. It is a $257 annual deductible this year, so you have to pay the first $257 total of all those services. And then after that, Medicare, as I said earlier, is an 80-20. Medicare covers 80% of the bill, you're responsible for 20%. But the biggest downside of having Medicare just by itself is there's no max amount of pocket or MOOP. There's no limit to your 20%. So if I went to the hospital for surgery and I just had a Medicare card, I'm going to pay the $1,676 per days if I'm in long enough. Plus, I'm paying 20% of a surgeon, 20% of an anesthesiologist, 20% of any doctor that comes and visits me. So if I had a $100,000 surgery, that's $20,000 out of my pocket. And because of that, that's what most people will get insurance to protect them from those. And Dave, you go to the next slide. That's where the confusion comes in with the different options. So the choices you have is a Medicare supplement or Medigap. That goes back to 1965 when Medicare first started. And that was the only choice people had until 2006. In 2006, the government introduced 2 new things: Medicare Advantage, which is now Part C under Medicare, and prescription drugs, which is now Part D under Medicare. So you have A and B original Medicare. Now we have Part C and Part D. So these are the choices you have to go with your Medicare to help you protect you from some of those costs. Now, as I go through these, there is no right or wrong or good or bad. And there's just different ways of getting your Medicare. And this is truly individual. And if you get nothing else out of this presentation, just know that in all these differences, it's what's good for you, not your neighbor, not your relative, not your friend. It's because everyone's different. And it's just understanding these, which is what I try to do, is explain all these options to you.
So Scott, real quick, if you need to take a drink, please feel free and go ahead. Is this the same for every state for for this part?
Yes. So all these options are national, except as you're going to see in a second, advantage plans and drug plans, particularly, they are subject by county. And there are still some counties in the United States that do not, they all have drug plans, but there's some places that do not have advantage plans. An example of that was Eastern Shore, Maryland, although that changed in the past couple of years. But all the first years I was doing this, supplement was the only choice that population had because there weren't advantage plans there. I can explain why later, but all this is national, absolutely. So another quick note here, if you decide to do a Medicare supplement or Medigap, there is no drug coverage under that plan. You must buy a separate standalone drug plan to go with it. Advantage plans, as you will see, can include drug plans in them. So you're getting C and D together. But I'll go through and explain those differences.
Scott, can you dig into the supplements a little bit?
Yeah, so
more?
let's take the first option. So the first choice people have is a supplement or Medigap. I call them supplement. It's the same thing. So people say Medigaps and supplements. It's synonymous. What these are plans that are standardized by the federal government. So the federal government, or CMS, which is the department that runs Medicare, they put the plans together. And unfortunately, like the government likes to do, they letter all these plans. So you have plan letters A through Plan N. Not to be confused with Part A or Part B of Medicare. This is Plan A, Plan B, Plan D. You see a whole bunch of letters missing because they've discontinued a bunch throughout all these years. As a matter of fact, they just dropped Plan C and Plan F for anyone turning 65 after January 1st, 2020. Plan C and F in particular, that was like the Cadillac, if you will. It was the most comprehensive plan. It would cover everything Medicare would make you pay for. So all the deductibles, all the per days in a hospital, you didn't pay a dime out of your pocket, but of course you paid higher premium for that type of plan. So anyone turning 65 after January 1st, 2020 can no longer buy a Plan F. If you were 65 prior to that, you can still buy a Plan F. So each of these letters represents a different plan design. Today, the most popular plan is probably Plan G, and Plan G is similar to F. If you see under Part B, that Part B deductible of $257 with a plan letter G, you have to pay the Part B deductible, which for this year is $257. Remember, that number can change every year. And after that, your Plan G covers everything else. That's probably the most popular plan. Again, you're paying a higher premium than some of the other letters, but it's the most comprehensive. The second most popular plan is a Plan N. Plan letter N, just like G, you have to pay the first $257, but now you also have a $20 copayment for every doctor visit and a $50 emergency room copay. But you're probably paying $30 to $40 roughly a month less than a Plan G. So some people choose to, pay less in premium and have something more to pay out if they use a doctor or service. Now, with Medicare supplement, when you first turn 65 getting Medicare, or if you're first getting Part B for the first time, say you're working till 60, whatever, 6, 7, 8, whatever it is, and then you're getting Medicare, you get what's guaranteed issue, meaning there's no medical underwriting. You're guaranteed to get the lowest price from whatever a carrier is offering. Now, I should have said these plans, the plan, A through Plan N, they're sold by a private company, but it's standardized by the federal government. So a Plan G is a Plan G. Doesn't matter what insurance company I buy it from, it's the exact same benefit because the government standard. Now, what they charge varies. But with supplement plans, there's no enrollment period. You can change anytime you want. You can say, hey, Scott, I'm healthy right now. Let me get, back up if you don't mind.
Oops, sorry.
That's right. Let me get a Plan A right now because I'm healthy. And then a month from now, a year from now, you say, you know what, now I'm getting nervous about my health. I want a more comprehensive plan. Let me get a Plan G. Well, now you have to go through underwriting, meaning they can pull your medical records, ask you medical questions, charge you more based on what they find, or even deny you, which is why G and N are the most popular because they're the most comprehensive. Because if you're in a Plan A, let's say, which is the cheapest premium, you still have all those deductibles come through to you, or a lot of costs come through to you. And then God forbid you get a cancer diagnosis, something like this, no one's going to write you. You're stuck in that A plan. No, so that's why when you pick a supplement, the idea is to pick one that you're comfortable in keeping the rest of your life. The goal is not to keep changing it each year. You buy it once and you keep it. Now the price is going to go up, and that's the thing with supplements. Is the prices are going to increase over time. There's 3 different ways that carriers price these. Most common is attained age or age banded. We'll take a 65-year-old, and then they usually split between gender, male and female. Women live longer, so their premiums are usually less. But and here's the price, and each year you get older, that price is going to go up at minimum. Now this is not regulated. Carriers can change the price anytime they want to. Anytime they get with enough claims and can justify it, they can increase the price. That's the number one criteria I use when I choose what carriers I represent. I look at what their average histories have been over time, and I select those carriers. Because logically, you'd say, okay, Scott, if a plan G is a plan G, no matter what carrier it is, it's the same benefit. I'll just go buy the cheapest one I can find. Well, here's why you don't do that, because some of those plans that are real low rate now are really high over time, and you want to avoid that. I get calls and I meet people now in their 80s paying for a plan F over $500 a month, where if they're with other carriers, they'd only be at $350 or under $400 a month. It can be that much difference, which can be tens of thousands over your lifetime difference. So that's why the carrier matters on when you pick a supplement plan. And
that
yeah.
differential between like an A and a G you
Yeah.
mentioned, is that, and I know significant is a relative term, but is the premium differential
Yeah, so
significant?
if you back up to that, yeah. So between the different letters, I'm gonna give a ballpark without quoting a single carrier. If you're a male, you're gonna be looking at between $140, $150 a month for a plan G. A plan A could be $63 a month. A plan N is going to be 105 to 110. It depends on the range, and the rates constantly change, and it's that time period you look at. It also depends where you live. It's different in Philadelphia than it is in Harrisburg or Pittsburgh. I mean, each rates are different all over the place. So I'm giving you central Pennsylvania rates where I am, but in Jersey and in New York, they're usually a lot higher than they are here. It has a function of how many seniors there are, how healthy that population is. I mean, there's a lot of factors that go into it, but it does vary. But on this slide, there are no networks or referrals. With the supplement, it does exactly what it says. The doctors only ever bill Medicare directly or facilities. Medicare forwards the leftover 20% to whatever supplement. So doctors do not have to participate with your supplement plan. You go to any country, or excuse me, any doctor in the country that is willing to see you that accepts Medicare. That's one of the benefits of a supplement. You're buying it and keeping it the rest of your life. You can go anywhere you want to, but Medicare is a fee for service. Just because a doctor has a Medicare contract, they're not obligated to see you. They can say they're not taking any more Medicare patients if he or she wants to.
Hey, Scott, real quick on that, we actually just had a question that came in that relates to this. What if somebody moves from
Great
one region to
question.
another?
Great question. With a supplement plan, depending on their carrier it can move with you if you're with a national company. Some carriers, you get a special election where you move to pick a new plan in the area you go to, but you're subject to the rates wherever you move to. So that's a very good question. Different than advantage plans. Now, advantage plans, which I'm going to talk about next, they are county specific. You could stay in the same state and move one county to another and have to change plans because that plan's not offered in the county you live in. But so just to recap on supplements, a supplement plan, you're paying more money up front in premium, but less cost when you use services, doctors or facilities. And over time, and because the price is going to go up. So say you're spending $150 a month with a drug plan and everything, that's $1,800 a year with a $257 deductible that you at least have to pay for plan G. The most comprehensive plan, that's a couple $1,000s a year. 10 years, by the time you're 75, you're going to be spending easily close to 200, if not more a month. By the time you're 85, you're going to be spending well over $400 a month on current projections. So, in 10 years, you're easily going to spend $20,000 plus in premiums. And this, if you're a couple, that's each. And over 20 years, you're each easily going to spend $60,000 plus over 20 years. So even though you're not paying much at doctors and places, it's still, you're paying something. It's in premiums and it's going up over time.
So
Okay.
you alluded to the advantage plans, which we're getting to next. Are the plans, medically underwritten, like Medigap supplements?
No, and that's so if we go to advanced plans, that's one of the biggest benefits is unlike supplements, these are guaranteed issue. There is no underwriting with an advanced plan. So let me back up just to say what these are, because this is a lot of people conflate the two, are not sure if I have a supplement or advanced plan. So I told you, and supplement started at the beginning of Medicare in 1965. It's paying after Medicare pays. You're paying more money up front, less cost of doctors. Advantage plans are almost the direct opposite. But what this is Medicare is paying a private insurance company to now manage your Medicare. So no longer are doctors sending bills into the government or Medicare directly. They're sending it to whatever carrier you're with, and Medicare is paying that carrier behind the scenes to manage it. So they're getting a chunk of money just by enrolling each person. But now, and so why did the government even do this? Well, the government's trying to save money. The number one cost of Medicare is fraud, waste, and abuse. It's estimated well over $1 billion a year it costs, and always has been. And say, okay, well, what does that mean? Well, you heard that term kicked around a lot now. But under the medical world, fraud. Yes, there have been doctors that have made up patients they never saw or tests they never did. It's actually easy to defraud Medicare because Medicare only has a few claims processing centers throughout the country. I can make up as a doctor all kinds of stuff. They're going to pay me. Now, they'll catch me through audits and billing patterns, but it might be years before they audit me or catch me. Now, fortunately, fraud's a small part because most doctors are honest, but it does happen. The biggest part of the cost is what's considered waste and abuse, and waste is the biggest out of those two. What that means is it's not necessarily intentional, but you as a patient, if a doctor's trying to diagnose something on you and say they order a whole bunch of tests or maybe even a procedure, how do you know what tests are needed to be done or not? Unless you're a doctor, you don't know. You're trusting your doctor, as you should. But when you have insurance, this is what prior authorizations are about. If anyone's ever run into where the doctor or facility, they wanted a prior authorization from the insurance company they needed before they could do something. It's not the insurance company trying to prevent you from getting the care you need. It's a check on the system. The insurance companies, and this goes back to the beginning of insurance, they've been doing this where they're looking and they'll follow a usual customary path and say, well, geez, we don't normally do an MRI when we diagnose X. Why did you order one? If the doctor, he or she, has a good reason, they're going to let you get it done. But if they're just saying, I'm being extra thorough, well, you could run tests forever. There's no check or balance. Well, Medicare with a supplement, there is no check or balance because the system is policing itself. So most of this is not intentional, but a lot of times things are overdone or things that really weren't needed or looked at. And again, it's an attempt to save cost. Right or wrong, I'm not placing a judgment, but this is the reason why these exist. Because the government said, well, geez, we don't have the infrastructure to do this nationally. Well, private insurance companies are already managing their own plans. Why don't we just pay them to manage Medicare? That's all this is. They're entering into a contract. It's a 1-year contract, which is why we have that October 15th to December 7th window. That's everybody's window to pick a new plan for the next year because the deck reshuffles each year. Unlike supplements, this is not something you buy and keep forever. You need to review it every year because the plans are changing, new plans come out, plans are canceled. The deck reshuffles each year. And there's a benefit to that I'll come back to in a second, but these are something, again, you need to have a look at. So carriers they pay the carriers based on the average cost in the county you live in. And I won't go through the whole algorithm, but that's why every county is different. Every county has different plans. It's based on the number of seniors. It's based on the insurance companies in that area, how much they're paid by Medicare. They put a plan together, and the plans vary greatly throughout the country. They have to cover everything Part A and Part B cover. Remember, the carriers are just middlemen. It's not like the carrier itself can decide what they want to cover or not cover. They're following Part A and Part B rules. If it's covered by Medicare, they have to cover it. If it's not covered, they're not supposed to cover it. Now, these plans usually have networks of doctors. And I'll go through those in just a second. They usually have cost sharing, like deductibles, co-insurance, or co-pays. Unlike supplements, though, these can include dental, vision, hearing, gym memberships, over-the-counter benefits, all kinds of things that supplements do not have, which makes them more attractive. And as I said earlier, the biggest thing is these are guaranteed issue. So the advantage part in the Pundit Advantage Plan is you're not deciding what you need the rest of your life. You're taking 1 year at a time with the ability to change plans with no underwriting. So but this is also why there are 0 premium plans in many areas. You can get a plan that doesn't cost you anything a month. You still have to pay your Part B premium, that $185 or higher. That you have to pay no matter what, whether you do a supplement or an advantage plan. But now you can get a plan, unlike a supplement, I'm not paying any premium, but now I have co-payments like you're used to from work or other insurance, so much at a doctor, so much at a hospital. All Medicare Advantage plans have a max amount of pocket, just like work coverage does. There's a limit to how much your copays are. And that's what varies between, the prices in the different plans. I might pay a higher premium to lower my max out of pocket. So the most powerful part of an Advantage plan is I could be in perfect health, do a zero premium advantage plan, God forbid, get a serious diagnosis like cancer or something, change to a plan, maybe I'm paying a higher premium, but now my co-payments are lower, my max out of pocket's lower, so it lowers my risk and lowers my costs. And then when I'm healthy, go right back to a zero premium. And you're taking 1 year at a time, not just shelling out premiums whether you're going or not. That's the main advantage, part of the pun advantage. The main thing is dollars. You have the opportunity to save money. No guarantee of saving money. This does not make it better than a supplement. There is no better or worse here. Some people prefer supplements. Some people prefer advanced plans. I've had multimillionaires that could afford anything do zero premium advanced plans because a dollar's a dollar. Even though they could afford anything, it's like, why waste if I don't have to? I've had some people who could barely afford it, prefer a supplement. They sleep better at night saying, yeah, okay, I have to pay that higher premium, but I don't have to worry about the Part B deductible of 257, and that's all I have to worry about. That's an individual person's call, which is what I try to do to explain to people and let each person decide what's best for them. Even spouses can be in different types of plans. There is not one right.
We did have a question. Somebody asked, they're turning 65 next year and their
Yeah.
selection in 2026 will cover them for about 7 months. Do they have to re-select a plan in October of 2020, in the following year, October of 27?
So, yeah. So all right, were they talking advanced plan or supplement?
Well, they didn't say.
All right, so a supplement
How
plan,
about each
once you
way?
pick, the goal is to keep it. You'll never change that. Now, remember with a supplement, there's no drug plan. So the Part D drug plans follow the same October 15th to December 7th. They're only 1 year contracts. So you do need to look at the drug plan. If you do an advantage plan, yes, they are only 1 year. You do need to every October 15th to December 7th. But that's a good thing because it gives you a chance to review. There could be a plan that's more competitive than the one you're in, or your health changed, and maybe the one you're in next year is going to cover one of your medications. That can change every year. It's something you need to look at each year, which again is what I do with my clients. Now go back one slide, Dave. There's one I skipped, and I skipped on purpose, but because with just Medicare Advantage plans, not prescription drug plans, just advanced plans, there's actually another enrollment period from January 1st to March 31st where you can make another change if you need to. So you actually have 2 chances to change. So here's how that look. Let's say, to help answer that other question, I'm enrolling in, let's say I'm turning 65 in August. I just got a Medicare Advantage plan starting August 1st. All I'm worried about is August to December, because October 15th to December 7th, we're going to meet again and pick one for 2026. And then the first quarter of 2026, January to March, if say I had another major medical change, I have another window I could change from one advanced plan to another advanced plan, guaranteed issue. So what it's doing is it's giving you a lot of opportunity to try to control your costs. But in the end, that is the difference. One way you're paying more money up front, less cost of doctors, guaranteed to spend a certain amount of money over time. The other way, you're paying as you go. And odds are heavy in your favor. You're going to save money. No guarantee to save money, but odds are very much in your favor that you will. And
Hey, Scott, what about prescriptions?
so they can be included in an advanced plan. That's what MAPD stands for, Medicare Advantage Plan with Prescription Drugs. There are some that are Medicare Advantage plans only. If you've got a veteran that's getting all their prescriptions through the VA, they don't necessarily have to have a prescription drug plan in their plan. So they make some plans for that population. And when we get to the final thing on prescription drugs, there's a late enrollment penalty for that. So if you're not taking your medications, you still need to get a prescription drug plan. I'll come to that in just a moment.
On the Advantage plans, I know there's, like we have when we're working, there's HMOs and PPOs and just all these different, yeah.
Yep.
Can
Yes. So
you
let's
shed
go
some light
through
on
these. Now, this does vary by state. There's a total of 5 in the country, but Pennsylvania example only has 4: HMOs, PPOs, private fee-for-service, and special needs plans. The 5th one is called a Medicare Savings Account, or MSA. We don't have them in this state anymore. We used to. I won't dwell on, but it's another type. It works similar to an HSA where you're putting pre-tax dollars into an account and using that money to help pay your costs. So if we go to the next slide, it's the HMO. I'm sure some people here may have had an HMO in their work history. That's health maintenance organizations where you have a network of doctors. You must stay within that network. Unless it's an emergency, all emergencies and all types of plans, no matter where you are in this country, you're covered as if you're in network. But if I'm in an HMO, and say, I say, you know what, I only use UPMC and that's all I use. And I'll never go anywhere else. And you look at an HMO, okay, because all your doctors should be in that, in that HMO network. But let's say you got a serious diagnosis and now you want to go to Cleveland Clinic or Johns Hopkins or you pick any place in the country. Yeah, and they're out of network in an HMO, it's not an emergency, you have no coverage. That's where PPOs come in. And PPOs next slide is a preferred provider organization. That's what most people like flexibility. So I'd say they're by far the most popular. But again, there's no good or bad or right or wrong here. These plans do have networks of doctors, but you're also allowed to go out of network. Now, some plans, a lot of plans are going to charge you more to go out of network. There are some plans that don't have the same copay in or out of network. It does depend on the county and where you live and what plans are offered, but it does give that flexibility to go to any doctor in the country willing to see you. So on a supplement, that's where it's a little easier in that any doctor in the country that takes Medicare is willing to see you, you can go to. On a PPO, you again can go around the network. Again, they have to be willing to see you and accept the plan terms and conditions. They still get paid their same Medicare rate, which means when they sign a Medicare contract, they're agreeing to a fee structure for every procedure. They still get that whether in the network or not. But again, they don't have to see it. So if people travel a lot, definitely this is the type of plan you want to give you those options. The next one is a private fee for service. There's only one carrier left that has one. It's like Medicare. It's a fee for service. You go to any doctor that's willing to see you, that accept the plan terms and conditions. Again, all emergencies are treated in network. And these are the same price, whether the doctor's in the network or not. And no referrals required. And the last type is a special needs plan. There's 4 different types of these. There's people with chronic conditions, such as there's 15 different conditions. The 3 most common are diabetes, heart disease, or COPD, or pulmonary disease. You're on certain medications that are real expensive. These plans help make those cheaper. There's also special needs plans for people that are called dual eligible. They have Medicaid and Medicare. And again, Medicaid, you have to be at a lower income bracket. There's different levels. I think there's 5 different levels to Medicaid. But these are the commercials, if you ever see them, where get your groceries, get Part B premium fully paid for. These are these types of programs. You have to be low income to qualify for that kind of stuff. People live in a long-term care facility, or people with end-stage renal disease or waiting for a kidney transplant. There's some areas that have special needs plans for that population. If you go to the next, oh, good.
Scott, you mentioned Medicaid, which I know is not our focus, but somebody did ask a question about being in a nursing home and has Medicaid as their backup, and they're asking, do they need to reassess their Medicare every year?
So yes, so depending on how you qualified for Medicaid, but yes, definitely, because if you qualify, there's Q and B, without getting the different levels, you could be open to getting plans where everything, if you qualify, zero premiums, zero copays, everything's covered. Dental, you get big dental, you can get groceries, you get utilities paid for, you get a lot of stuff. So even in nursing home, if you qualify for Medicaid, it's worthwhile checking to see what level, which is something I can do, and see if you are now open to get these plans. Now, the downside of special needs plans, they're only HMO. So you got to make sure your doctors or whatever facility you're in takes the plan. So that might limit you to what options you have, but still, definitely you should look at that. If someone qualified for Medicaid, you'd want to know if you're qualified for one of these types of plans, because they're very, very good.
And just one more question about changing plans. Somebody just asked if you can change, if your health changes outside of an enrollment period, can you change the plan, or do you have to wait till a window comes around?
All right, good question. So with the supplement, you can change anytime, but you have to get through only the first time's guaranteed issue. You have to get through underwriting. With an advantage plan, you have to have a special election window, which there's a number of them, but the most common, obviously, is the annual enrollment period, which is October 15th to December 7th. You pick, the plan won't start till January 1st. Then you have the open enrollment period, is that January 1st to March 31st. It'll start the first of the next month. So if you change in January, it'll start February 1. You change in February, it'll start March 1. You change in March, it'll start April 1. But from April through December, you're locked into that plan unless there are other special enrollments, such as if you move. So if I move from one county to another county that my plan's not available in, then I get a special election to pick a plan where I move to. and there's other ones, but that's probably the most common. But no, so you are looking at a lock-in period from April to December for most people.
Hey, Scott, as we move on, can you talk to us about the cost components of the Medicare Advantage plans?
Yeah, so advanced plans, this is a weird thing to shop for because it's not like shopping for most things. Paying a higher premium does not guarantee you're going to save cost less for stuff. If you end up, I always start looking, you start with looking at the zero premiums and then go up from there based on what your needs are. And you have to look at different plans. In most areas, they go all the way up to $300 or more a month for a Medicare Advantage plan. You're saying, well, why would someone spend that much? That's more than a supplement at age 65, a lot more. And the answer is you're right. Few people should ever spend that kind of money. But what those plans typically do is they cover certain prescriptions that no other plan covers. The bottom line, it should do something for you. If that $300 a month plan is saving me more than $300 a month on my medications or on upcoming visits or hospitals or whatever I'm getting done, then it's worthwhile being in that plan. But I've met people taking no medications, hardly go to the doctors, paying $300 a month because they think they bought the best plan out there. You are throwing your money away. It doesn't work that way. And each carrier is different, which is why you have to analyze. And each count number, in central Pennsylvania here, I'll use in Cumberland County, there's 87 different Medicare Advantage plans. In Franklin County, there's 63. In Lancaster, there's 85. It varies. Every county is different. So you want to look at what's available, which is the service that I do here. And I try to, I'm licensed with the majority of carriers. I do compare against them all to help people find what's best for them. But the biggest disservice is just buying based on price. It's like a puzzle. To find how do I pick out 87 different plans? Well, I start with your prescriptions. What carriers have your prescriptions the least expensive? Then what has your doctors in the network? What do you travel? Do you travel internationally? Then we look at the dental, the vision, the hearing, and we narrow it down based on all that. It's never just one thing. You got to look at the whole picture. Most of the ads you see advertised and all the junk you get in the mail, they're trying to get you focused on just one thing to pick their plan, but you can't. You're doing yourself a disservice if you do that, because I could make any one plan look great based on one thing. You got to look at the whole package and does it fit you? And again, reiterating, it's individual. So even spouses can be a different plan just based on the prescriptions they take alone. One carrier might cover it where that same carrier isn't covering the other one. So it's truly individual.
So Scott, it's like a weighted matrix, and for each person, they're going to have different things they're weighting more or less than their neighbor, friend, whatever.
Exactly. That's exactly right. It's a system changing, and I get why people do, because you're trying to find someone you can trust that, hey, what should I get? Because it's confusing, and that's I totally understand why most people do that, which again, I try to help it, which is why I try to license with every carrier or show you every carrier, because I'm not shoehorning people into what I have. I'm looking at the whole market, trying to explain and let people decide for themselves what's best. On this next slide, they do have the Part C and Part D star ratings. If people ever saw their Medicare new handbook or anything like that, you can see star rating systems. It's out of 5 stars. This is Medicare's control. It's not Medicare saying buy this plan because it's a high star rating. They're saying they're doing what we want them to do under their contract. They're following, they're catching overbilling, they're catching mistakes, their customer service is good. One of the big factors is how many members get preventive tests. The government's real big on preventive, which you get aortic aneurysm screening, bone density, mammogram, cervical cancer screening, prostate cancer screening, colonoscopy, flu shot, pneumonia shot, COVID shot. Each year you get those. So, or most of those. So how many members are getting those tests done? That's a lot of what goes into the star rating. If a plan gets to 5 stars, you can enroll into that plan anytime throughout the year. So going back to a question you asked, Dave, if I'm in a Medicare Advantage plan and in my county I have a 5-star plan available, and say I develop a serious like cancer or something, can I change plans? If there's a 5-star, I got to change in the middle of the year. So that there's a lot of scenarios, which is why it's always wise to check with whoever you're working with to see if there's options available to you.
So how important do you need to use cost to weigh the decision making when you're kind of looking at all your different options?
Yeah, so again, that varies by person. So, some people I have make sure I understand the question. You're saying deciding between a supplement or advantage plan type thing, the cost differences?
Yeah, when you take a look at the whole thing in the matrix,
Yeah.
how important is cost?
So again, each person's going to answer that uniquely. It's again, summing it a supplement, you're paying more money up front. You buy it once. The drug plan you have to change each year, but the medical you just leave. Its cost is going to go up, but it just works, and the rules don't change. So it's going. But you're paying, a higher premium for that. I have a lot of people that say, you know what, for that same $150 a month, I'm ballparking again, for a plan G, I could pay myself that, get a zero premium advance plan, and I'm saving $150 a month building up. So if something does happen to me, and say 5, 10 years from now, I'm sitting with $10,000, $15,000 or more to cover my max out of pocket. So financially, that works very well for I have a lot of clients that do that, and that works really. Now again, some don't have the discipline or don't want to do that. You don't have to. And again, you have the ability to change to go to a plan that has a lower max amount of pocket. If something happens, we'll use one of the windows or whatever window we have to do that. But I will tell you, in my years of doing this, I have yet to have somebody not save money doing an advantage plan. It's potentially theoretically possible, but odds are heavy in your favor because you have that ability to change. Again, doesn't make it better than a supplement. It's if I don't mean to be flippant about this, but if money doesn't matter, supplements are easier. If money
Sure.
does matter, advanced plans are going to give you the control over that. So the last puzzle piece to all this is prescription drug coverage. As I said, this is Part D. It can be included in an advanced plan. So you're getting Part C and Part D together all in one thing. If you do a supplement, you have to then buy a standalone drug plan by itself. So if you go to the next slide, now, if you said, hey, I don't take any prescriptions, therefore I don't need a drug plan. Well, Medicare penalizes you if you don't take one when you're first eligible. And for a drug plan, it's either Part A or Part B. So again, going back to someone who's 65 and going to continue working, that drug plan in your company plan is usually creditable. If it's not, again, they have to tell you. So you will get out of this penalty. So that same form that you're going to use to get out of the Part B penalty, you're going to use it to get out of the Part D penalty as well. But a lot of people, especially when this first rolled out in 2006, because of course everyone's only on supplements, a lot of people say, I don't take any drugs, I'm not going to buy a penalty. Well, they penalize you and they calculate it. It's based on the national average base premium, which for a standalone drug plan, which for 2025 is $36.78. It's 1% of that. They round it up. So it's 37 cents for every month you went uncovered when you were eligible to join, but didn't. So 30s, just calculate. It's a year. I mean, it's 37, a little over $4 on top of whatever drug plan you get for the rest of your life. And if the national average premium goes up, your penalty goes up. So you want to avoid it. And especially today, as I said, you can get a zero premium advantage plan that has a drug plan in it. So it's not costing you anything. And there are low cost in many areas drug plans if you need to do a standalone one. Just buy the cheapest one because just to have it to avoid the penalty.
Hey, Scott, I know this probably doesn't apply to a lot of the people on the call, but are there generic opportunities and um, discounts and things of that nature on the drug side?
Yeah, so they simplified it for 2025. So I don't know if anyone on the call has ever remember or hear about the coverage gap or donut hole that put in 2006. This is one of
I
the
was
most
going to ask about that.
confusing
Yeah.
things. Fortunately, it's gone. I'm not going to go through it. It's long to explain, and it's gone, so we don't have to worry about it. But what they did, there's 4 stages. Now there's only 3. First stage is deductible. If a plan has a deductible in 2025, the highest it can be is 590. This changes every year. It's going to go up again next year, but it can be from 0 to 590. So either if your plan doesn't have a deductible or if your plan does have a deductible, once you pay it, then you go to initial coverage. Now, initial coverage is where every carrier puts together what's called a formulary. And a formulary is a list of what drugs are covered under that plan. This is one of the most confusing parts to all of this is because each carrier can take any drug and put it in any tier they want to. And by tier, I mean tier 1's preferred generic, tier 2's non-preferred generic, then you have preferred brand, non-preferred brand, and specialty drugs. And obviously the lower tiers are the lower cost to you. So I could be taking a generic and one company could price that like a brand, take a brand and price like a generic. This is what separates all the carriers, which is why this is the first thing you separate. Now, the other thing is each carrier does not have to cover every drug. The best way to think about this is Medicare is a master list of what prescriptions are allowed to be covered because the carriers can only cover what Medicare approves. A formulary or what a carrier puts together is a subset of that. All Medicare tells them is they must have at least two of every therapeutic category of drugs. No matter what a doctor's trying to treat you for, there is something in your formulary that he or she can use. It's just a question: A, is the one your doctor wants to use, and B, what tier is it in? How much is it going to cost you? So that's why it's very important each year to look, because just because they covered your drug at one tier one year does not mean they're going to cover it the same way next year. This changes every year, which is why this has to be reviewed. So that's initial coverage. So that's what separates. Now, the big change when they got rid of the coverage gap or donut holes to get to stage 3, the catastrophic stage. Now there's a maximum out of pocket limit of $2,000. If the cost of your medications out of your individual pocket, you spend $2,000, then all your medications are not, there's no cost the rest of the year. That's the most you can spend in a year. That's the good news. But there's a caveat to that. The drug has to be covered by the plan. It has to be the plan's formulary. So if the plan's outside of the formulary, there's no dollar limit. You're paying the full cost. Now, everything's appealable under Medicare. So you could, if say a doctor wants to prescribe something to you and you go to fill it and it's real expensive, or say it's not even on your formulary, the first question should be the doctor and pharmacist, what other drugs are in this category? Because I bet there's another drug that they are covering, treating that same condition. And if there is, and hey, doc, can I take this one? They say, yes, you're good. If they say, look, I don't care, I want you taking this one, you can file a tier exception with the carrier and see if they can get them to cover it. Carriers are pretty lenient on this because they do want people taking their medications, but you can't just say it yourself. You're going to have a letter from the doctor. There's an appeals process to do it, because doctors don't know what's in your plan or not when they're treating you. They're just trying to use what drugs they know would work. So don't just take everything at face value. Everything can be looked at and fought. But again, once you've hit $2,000 limit, then drugs are free the rest of the year. I do know it's going up to $2,100 next year, so they didn't raise that very much, but it looks like. But there's no insurance to get out of it. The only way to get out of it is if you qualify for lower income. There's extra help from Social Security. This again, this is a national thing. If you have certain income levels, and they do look at assets. So it's an income and asset thing, but if you qualify, they can help pay your Part B premium. They can, cap your generics at $4.90 and $12.15 for a brand. In Pennsylvania, we have Pace and PaceNet. I know not everyone here on the call might be from Pennsylvania, but this is what our state lotteries pay for. PaceNet for married couples, $41,500 a year or less. For a single, it's $33,500 a year or less. Here, they do not care about assets. It's only income. They cap your generic and brand name prescriptions. So those are helps. And each state might have something like this. You can check if you're not in Pennsylvania, if your state has a program similar to this. Again, in closing here, everyone's unique. There is no one best plan. I get asked all the time, Scott, you're with all these carriers, who's the best? There isn't one. It's truly what's best for you as an individual. And it's worth the time to review. It's hard to do yourself, which is why I do what I do. Most people have a plan based because of a friend or relative, and most people are spending way more than they have to as a result. If you go to the next slide, what I do, again, at the Alera Group, I have a free service. I do not charge for what I do. I'm paid by whatever carrier you enroll with. I'm not biased, but truthfully, if something's best for you, I'm not licensed with, I will help you get it. I always help my clients because everything's transparent. I'm showing you everything. I help you decipher in your county and look through all the different plans. And also, I'm available all year round. It's not just like you see me once or every October 15th, December 7th, anytime throughout the year. If you get a bill you're not sure of, if you have a procedure, hey, what's this going to cost, or any questions, you need to know if a doctor's in your network or any help, I'm there to help all my clients. And that's my goal, is to help people find the right plan for them. I'm licensed, me personally, I'm licensed in 11 states, but I will help anyone in the country. I have clients that have, relatives in states I'm not licensed with. I will still help them. I'm happy to do it because most people, it's a confusing thing, and most people are paying more than they need to. So.
Hey, Scott, real quick. So I have your contact information
Yes.
right up here. One thing I found that was very interesting is if people need to have more questions, they need to reach out to you directly.
Thank you for bringing that up. Yes, Medicare has very strict marketing rules. There's no cold calling, which is why anyone, if you've just turned 65 or know somebody does, why you give a BART in the mail, because that's all anyone's allowed to do directly, unless you give them permission. But that's why the mailings you get, they trick you. They make it look like it's come from Medicare or something official. As soon as you send a response back, you just gave them permission to now call you. And now that doesn't mean some people still call you, and that's highly illegal. They could lose their licenses for doing it. But if anyone has a question that you need to call me first or email me that, and they'll, give me permission to contact you. If you're talking to Brad or Dave, they can't just give you your number and have me call you. You still need to make first contact with me.
All right. So
We've
I
got
know,
maybe
Brad,
time
please.
just for a couple quick questions that
Absolutely.
get to. I think some of them are pretty straightforward, but my husband, one says my husband, not my husband, but her husband turned 65 2 years before her. She carries the benefits. Does he have to sign up when he turns 65 or when she retires?
So the first question is, if there's 20 or more employees, then no, he can stay on that company plan just like you're going, and he gets a special election when you leave the plan. But you should analyze and see, because I don't know how much you're paying to cover a spouse. A lot of times with a lot of companies, it's more now where Medicare can actually be cheaper for you than stay in the company plan. I can help you analyze that. But no, he can stay on it, and he gets a special election when you leave. Now, if there's less than 20 employees, then he has to get Medicare Part A and Part B.
And
So
some of
how
these,
does the penalty work, Scott? Let's say somebody's 68, 69, they've never signed up for Medicare. Do they now have a 48% penalty?
It's 10% for each 12-month period. So if that's 3 years, that's 36 3 years, 30%. So 30% of 185 tacked on monthly for the rest of your life. And as the 185 goes up, your penalty is going up.
and Scott, some of these are overlapping. There was another one about signing up for Part A when I turn 65, even if I'm with a qualified employer. This is the
So
only other one that might be unique. I'm 65, still working. My insurance is covered by my employer. If I retire outside of the Medicare enrollment period, the October to December, do I enroll at that point? Say, May or June.
okay, let me clarify. The October 15th to December 7th is only for Medicare Advantage plans and drug plans. That's not
Okay.
Medicare. That's just for those. So you have that 7-month window when you turn 65. Outside of that, you get a special election if you leave employer coverage. You get a special election to pick up Medicare. You have 8 months to get it before the penalty kicks in. Now, most people don't want an 8-month gap in insurance or lapse without anything, so they usually do it seamlessly. But the Part A, if you remember, if as long as you're not in a health savings account at work, then you can go ahead and take Part A. It doesn't hurt you because it doesn't cost anything. Now, something I should clarify back on HSAs. It's only the account holder that cannot have Part A or Part B. If you're a spouse, so say, like in that situation, say the one spouse is working in an HSA, the other one is just turned 65. If they got Part A, that does not mess them up. It's only for the person that's the employee that can't have Part A or Part B. So the spouse can have Part A because it's free and doesn't hurt you. But if you do not have an HSA account at work, you can, if you want to take Part A, you can. Remember, Part A is only covering room and board of a hospital, hospice care, some blood transfusion. It's not, chances are you'll never use it, but it doesn't hurt to, it's not cost you anything.
Well, listen, I think we're a little bit over our hour. So Scott, thank you so much for all, your expertise. My big takeaway is that this is so personal, and as you just got to be looking at it all the time as your circumstances change. I'll put a quick plug in. Our next webinar is going to be October, August 19th. It's going to be titled Unlock Your Hidden Income from Your Investments. And it's going to be geared at really for folks, anybody that's sitting on a large stock or mutual fund position that is really too big, but they're hesitant to sell it due to fear of capital gains taxes. We've got some solutions for that. So look for that on August 19th, I think also at noon. And just in closing, Dave, thanks so much for, co-hosting this with me. Scott, thank you for sharing, again,
Oh,
all
thank
your
both of you.
expertise, and thanks to everybody for attending. Hopefully hopefully everything hit the mark.
And if there's any questions that we weren't able to answer for you, please do not hesitate to reach out to myself, Brad, Scott directly, or your advisor here at Fort Pitt, and we'll get you the right answer and in front of the right people.
Again, Brad and Dave, thank you so much for the opportunity. And anybody, yeah, please feel free to reach out to me if you have a question.